So this is my case study, Barbara. I'm doing my case study with about frailty. It's a little bit of information, her diagnosis. So she was admitted to hospital because she had a fall at home, which resulted in a cut and a bruise on her head and possible concussion. She was then put into hospital and then put on the observational ward for a 24 hours observation and advised to stay overnight for the night. So if I click on to the next slide. So what is frailty? So frailty is defined, I don't know if you could read that. Yeah, frailty is defined as a biological syndrome of decreased reserve and resistance to stresses resulting from circulative declines across multiple physiological systems and causing vulnerability to adverse outcomes. So frailty syndrome includes, syndromes and symptoms include falls, immobility, delirium, incontinence, medication or side effects. One more of these should raise concerns about the individual's frailty. So the way we could assess the frailty is the clinical frailty scale. So this is developed to create a summary of an older adult's overall degree of frailty or fitness. So we could use this to base our interventions on to see, what level of frailty they are currently at, and what we can do. So moving on. So for the model, I am using the Moho model of human occupations. I've used this because, let me just go on here. So by using the Moho, occupational therapists can apply the principles of support to their daily work. It also enables us to create and practice that is occupational focused. So a variety of evaluation tools can be employed to support this. And then, so for the purpose of guiding the occupational based interventions, we can offer Moho an occupational therapy procedure that can be used to improve Barbara's occupational performance. So along with this, I will probably use I'm going to use Kilhofner's 6 steps of reasoning, or 6 elements of occupational process. This includes developing questions, learning about the client, developing a conceptualization, setting goals and plans, and putting those plans into action. So these have been utilised to give meaningful planning and interventions. By using this occupational approach, we can evaluate any activity a patient is doing or not doing. It also utilises a top-down holistic approach to looking at the individual, their meaningful activities or occupations and the relationships with their environment. This can lead more to an occupational identity than the other models that I looked at. So for Barbara, her independence and maintaining it in decisions with her care will have a much more positive outcome for her care, I believe. There also is the ICF model, which you can use. That's meant to be, so the ICF considers a person's degree of functioning as the outcome of a complex interaction between personal, environmental and health related factors. This was another one I looked at, which was quite good. So quite often the phrase of living with frailty, the word frail is not often expressed with elderly people. So adults who are elderly do not typically characterise themselves in the terms of frail. Instead, they get a coping mechanism with frailty, which involves problems which can occur. So the mental and physical health of elderly adults is demonstrated by their independence in doing daily duties. So maintaining that independence is a really top priority for those older adults. They can often feel like a burden, or, they're not in control, and they don't like to tell their families either. So they can quite often not speak up. So I've also put some, some of the rough questions that we can get some ideas on when starting your OT process. And then I looked at the risks and priorities. So, we've got risks of recurring falls. Quite often when an elderly or anyone falls, it's quite it can be quite frequently after. So recurring falls can be quite off the effects of recurring falls. So, sorry, let me start again. A person's risk factor of falling are frequently unknown until they actually encounter one. So depending on the environment, fall risk and fall prevention interventions may change. So it says that within a half year, half of those who fall will do it once more again. So then we've also got look at the anxiety which this can cause from falls. They would be quite worried about mobilising again, and it can create quite severe anxiety about it. And we'll look at the environment within the home. So Barbara lives in a house with stairs. This can be a risk for falls. She is very independent and likes to do everything herself. This is a good thing, but it can also mean that Barbara can decline assistance offered to her because she wants to do it herself. And Barbara is slowly losing weight. This can cause her to become more frail. She's drowsy. This can cause other side effects. So from her medication, falls can become more dangerous in this. And then there can be further indications of frailty from the fall. So from her falling, we can then look at maybe there might be other symptoms that she's been getting or other symptoms of frailty. So we can also look at the priorities, which is a list there. So to reduce the risk of falls, injury, outside and inside the home. Assessment tools. So I looked at a range of assessment tools that we could use based on Barbara's case study. So I looked at the CGA assessment tool. That was quite a well-recognised one. The daily activity assessment tools, fall assessment, so Berg balance scale, the Paul activity level for occupational profiling, home safety self-assessment tools, fall efficiency scale, which accesses the levels of fear of falling, the Berg balance scale, the electronic frailty index as well, and also a lot of the multifactorial assessments can include assessments of balance and mobility, gait and muscle weakness, falls history, their fear of falling, osteoporosis risk, urinary incontinence, and home hazards. So I looked at some long-term goals and some short-term goals for Barbara. Her long-term goals being to promote and to maintain independence in daily activities and care needs, enhance occupational performance, support with social participation, so relationships, quality of life and well-being, prevention of hospital admissions and to remain living at home for as long as possible, environmental adaptations to prevent further falls and to enhance ADLs, a good nutritional diet to maintain healthy weight and to reduce further weight loss, reduce the risk of injury and falls and to reduce the risk of falls outside and inside the home. One long-term goal I chose is within 6 months, Barbara, let me just make this a bit bigger, sorry. Barbara will continue to carry out daily activities safely within the home. So some short-term goals. Barbara will participate in Tai Chi for 10 minutes daily. This can be done in a chair at home or standing up from the chair to improve balance and muscle strength. This will be reviewed every Friday by an occupational therapist. So using these exercises have actually been known to improve, interventions and really engage well with elderly. So the interventions that I looked at, so we could look at getting equipment around the house, so alarms to alert services that Barbara has fallen, or to alert someone that, you know, she is at high risk of a fall. So we can assess her house for home safety and make changes. So we could also have a pendant that she could wear around her neck just to press the button if anything happened. We could look at using a rollator when walking around the house, just to mobilise a little bit more easily for her. And then we'd also probably look at things, you know, you could also get like sensory mats. She also tripped when she was ironing, so we could look at rugs, you know, within the home, carpets. What can we do? Any clutter to be taken out of her home to make it safer. She's got stairs at home, so we could put a stair rail which could prevent falls on the stairs. We could also look at care support, you know, if she needs that extra support with care. We could look at advising Barbara to if something does spill or get knocked over, to immediately pick it up or get rid of any trailing wires, using non-slip mats and rugs. We could organise the home so that climbing, stretching and bending are limited. Also, taking care of your feet is a very good way of preventing falls. You could get close friends to check in throughout the day. So this could be the two sons that come in once a week. They could, obviously not enough, but not as much as what we would probably like to, but they could maybe fill on days that her close friends can't, or any care support workers. Gait training and advice on appropriate use of assistive devices. Review medications with the GP. Exercise programs, like I said, so you've got yoga, Pilates, Tai Chi. Let's go down. So there is a lot of evidence that early identification of assessments and early intervention can have a significant impact on people who are at risk of falling. These individuals are encouraged to take positive risks, increase their activity and build strength and balance in order to improve their health and well-being and reduce their risk of falling in the future. So occupational therapy intervention delivered in hospital, home or a community setting has been shown to improve functional ability, social functioning and quality of life. So this is going to be showing like scientific reasoning throughout the whole intervention process and assessments. There's a few more there. Just go down here. So the frames of references I've used throughout the process are the compensatory frame of reference. This aims to improve occupational performance and independence throughout the use of techniques. This was chosen for Barbara to use throughout the process because her independence is very important to her. It is used to compensate dysfunction in desired occupations. So assistive devices are used throughout. It also includes environmental changes, so such the layout of homes. So it works really well with the OT process. And also biomechanical frame of reference. So this has the potential to correct the underlying impairment, improve occupational performance. So goals include using therapeutic and occupational-based activities, which is what we want to do after she's had a fall, you know, to improve her mobility a little bit more and, you know, to reduce that anxiety if she has it. Or to reduce that reoccurring falls. So assessments and interventions for static and dynamic orthosis. So ADL performance, work hardening and nerve gliding emerge from the biomedical frame of reference. This is all, this can all be caused by obviously medical conditions as well. So from the frailty. So the evaluation outcome, let me just double check there's nothing there. So I've said that, so we've kind of highlighted social interaction, which has been improved by studies. We've done that from the goals. We've looked at the NICE guidelines recommended to assess and reduce risks in older people. We've looked at continuously using assessments throughout. So one of those can be the comprehensive geriatric assessment. So Barbara, I think, would really benefit from that assessment. but it might be completed after she's released, so after her discharge from hospital, because it can take some time, but it takes a really holistic approach, and it's very independent to that person. It's got great like planning and intervention for frail patients. It's really beneficial for them. But this is probably one for after. So also, the ability to screen at-risk frail and slightly frail people is especially important because the progression to frailty is not inevitable, and evidence suggests that it's possible to slow or reverse its development. So continuously doing assessments for Barbara would be beneficial with her treatment, just because with frailty it is a progressive disease, and it can become worse as time goes on. So during that time we would have to look at a wider range of, you know, maybe other assessments that we could use for it, just based on her declining in her mobility or her health. And by doing this and using these assessments, we can apply evidence-based practice, which we can make sure effective interventions are achieved, outcomes are achieved to deliver the best quality of care. Quite often with the care and throughout of this process, we wanted to ensure that Barbara's care was catered to her, and you know, her meaningful occupations and what she wants, and quite often people are classified and divided as a consequence of ageism. This can be where they are treated differently from the other population as a result of being elderly. And we don't want this to have an effect on her care at all. So making sure that we make sure her care is fair and to her needs throughout means that we are giving her the best care that we can give her. So other multidisciplinary teams, so we've got primary healthcare teams, so we can look at maybe a care package for Barbara. We've got oncologists, so review her medications with her nurse at the moment, see if there's any other medications she can go on. And you've got voluntary organisations providing services for older people, so local charities. So these can include maybe doing the Tai Chi and yoga in a different place, or maybe you've got local support groups with social care for long-term conditions, or a local support group to maybe for Barbara to go to. And then you've also got a number of organisations recognise the benefit of interventions to maintain and improve the mental wellbeing and independence of people of 65 or older. So these are the Chartered Society of Physiotherapy and the Royal College of Nursing. And you could also look at a dietitian for support within her nutritional needs and physiotherapy. And there is a discharge summary based on what I have gone through and what we want the positive outcomes from doing all of these assessments for Barbara will be with independently living at home, and reassuring that, you know, the risk of injury or falls is reduced dramatically and it doesn't happen again, or to put things in place that can prevent it as much as we can or are able to.